My name is Dr. Mohit Bhutani. I'm a respirologist and a professor of medicine at the University of Alberta. Once we make that diagnosis, then we can sort of take a look at the severity and we have to take a look at their symptoms. What is their day-to-day life like? What is their quality of life like? What is their history of having these flare-ups? And how is the disease expressing themselves in an individual patient? We put all that information together, and we then develop a management plan that includes both pharmacological therapy, so inhaled therapies, and also, as important, non-pharmacological therapies that help empower the patient to get the best outcomes when they're diagnosed with this disease. Once the damage with COPD develops within the lungs, it's permanent, so it doesn't go away. So if you stop smoking, whatever lung function you've lost, you have permanently lost that lung function. You can never regain back that lung function over time. But what the benefit of smoking cessation is that once you stop smoking, within about 6 months, your natural loss of lung function goes back to where it is if you had never smoked. Second thing is vaccinations. As we said, that viral and bacterial infections are the #1 causes of flares, and those flares can happen across all severities of those diseases. So we want patients to get vaccinated yearly for flu and for pneumococcal vaccinations as well. The third thing is exercise. So it is, without question, probably the most important intervention. What patients with COPD tend to do is they tend to accommodate. They get breathless with activity, and what do? They stop doing the activity that they normally enjoy to do. Whether it's playing with grandkids, whether it's playing on a team, whether it's hockey, basketball, you name it, whatever they want to do, they tend to stop doing that as vigorously or as frequently. So making sure that they maintain a good exercise program. Now that can be done individually, talking with a physician about setting goals, or it can be done through a formalized program called pulmonary rehabilitation. And so pulmonary rehabilitation is a program that is designed to help educate patients with COPD about the disease and about what they can do to help the best outcomes, and at the same time provide them with exercises that we know can help improve the long-term outcomes for COPD. And the last thing is developing a partnership with a certified respiratory educator. And so an educator plays an important role in terms of knowledge translation, trying to make sure that patients completely understand what the disease is, how to use their inhalers, developing things like action plans, so what to do when your disease might start your symptoms might be becoming more aggressive. And so what can you do to intervene so you don't need to go to the hospital or need to be hospitalized for this to prevent that from happening. So those principles together kind of formulate what we call self-management in terms of how to prevent the disease from getting worse from a non-pharmacological standpoint. Any chronic disease the prognosis is defined by many different factors. Okay, so 1 is defined by your age, 2 is defined by the severity of the lung function that you've got when you get the diagnosis of the disease. A third factor comes into what other medical conditions do you have, and what we're seeing right now is that patients with COPD, although the disease might start within the lungs, there's a lot of good understanding that other what we call comorbidities exist within COPD. So things like heart disease, osteoporosis, even psychiatric illnesses like depression and anxiety, because you can imagine if you can't breathe, it can create a lot of anxiety for patients. So all those factors kind of come in together to sort of determine what your prognosis is going to be. And as a physician, I often tell my patients that I'm a guide in terms of this journey, but you need to be the active participant in reaching those goals.